Hi, it's Dr. Centeno, and thanks so much for joining us today at You've Got the Power. We're going to be talking about the vagus nerve today and how you can diagnose vagus nerve irritation from the neck. Now, the reason why this topic came up is we had some patients who would come to the clinic with these fancy ultrasound reports seemingly showing that they had a vagus nerve problem. And so did some research, tried to see if there was some research behind all of that. Certainly, we know that we have a lot of patients with vagus nerve problems due to craniocervical instability and other neck issues. There's been now a wide body of research on how vagus nerve dysfunction can cause all sorts of problems, including blocking of the anti-inflammatory or the resolution of the inflammation response, as I talked about in a previous video. But today we're going to focus on, can you use imaging to diagnose a vagus nerve problem caused by CCI or another issue in the neck? So we'll be delving into that, and then obviously we'll go to Q&A, just like we always do. You can ask questions about this or really any topic at all. So again, today we're going to focus on that concept of, can you diagnose a vagus nerve problem in the neck using ultrasound? And if so, how would you go about doing that? We'll also reveal some new research that we're going to be doing in that area that'll just be part of the standard evaluation. We won't be charging for a fancy report, et cetera, et cetera. So let me go ahead and share the screen, and we will go ahead and start that presentation. So how do you diagnose a vagus nerve problem in the neck? So vagus nerve symptoms, some of the biggest vagus nerve symptoms we see patients show up with who have craniocervical instability is really POTS, changes to heart rate and blood pressure. Dizziness, a lot of our folks have, but that's usually related to upper cervical problems. We certainly hear a lot of GI issues related to vagus nerve problems and nausea, but again, that can overlap with the upper cervical spine. So those are the biggest things we see when patients walk in with vagus nerve issues. Now, the vagus nerve, as you know, starts way up here, comes out as cranial nerve 10, and then goes right in front of the upper neck, and then goes all over the place, goes into the heart-lung complex, goes into multiple organs, including the organs of digestion and others, and into the spleen. And we talked in a previous video about how anti-inflammatory macrophages that get produced in the spleen by the vagus nerve then go out into the body and help control inflammation. So if you've got chronic vagus nerve issues, you can get pro-inflammation. In fact, there are now vagus nerve stimulators that they're studying to try to see if they can treat problems like rheumatoid arthritis and the chronic inflammation associated with rheumatoid arthritis by stimulating the vagus nerve. And again, this is sort of what I just discussed, this concept that the vagus nerve is not just dealing with your heart or your digestion, but also definitely controlling the anti-inflammatory reflex. So the vagus nerve is related to the neck. We've been over this one before, is that it goes right in front of C1, C2 here. So if you've got C1, C2 instability, you can certainly get irritation of the vagus nerve. Same thing with C2, 3 instability, etc. And obviously, a lot of our patients come with the diagnosis of POTS. So their vagus nerve problem is causing them to have heart rate and blood pressure issues when they are going from lying down usually to sitting up or standing up. And if we're going to talk about imaging for the vagus nerve, we can talk about CT scan, MRI, MR neurograms, and ultrasound. And ultrasound is probably the best of these, in that it's the least expensive. The vagus nerve is relatively easy to see on ultrasound. Might be a little harder if you had a really heavy patient, but in most patients, pretty easy to see. So ultrasound is probably the way you would want to go if you wanted to look at the vagus nerve. Now, why would you want to look at the vagus nerve? Well, one reason is many times when nerves are getting irritated and really in dysfunction, they get bigger on ultrasound. So you can do that with a carpal tunnel diagnosis in the median nerve, for example. And this is what it looks like. So this is the ultrasound probe here in the neck. This is the carotid artery here, or the internal carotid. This is the internal jugular vein, and sitting right between them, this yellow area, is the vagus nerve. So you can trace that and you can get what's called a cross-sectional area on the vagus nerve. So it's, again, really easy to see. But I was surprised by this fancy report that I looked at, because it seemed to suggest that if we measured the size of the vagus nerve, we could somehow then connect that to the patient's CCI. And so I went looking for some research that would explain all of that. Now, what I did find were some standardized measurements in normal patients. So those are the things I have here. Now, what's interesting here is that there's actually 3 studies like this. This is the one that's done in younger people. There's one done in older people that has larger numbers. So probably possible to figure out what size the vagus nerve should be in a normal person. But there's really nothing on CCI and vagus nerve that's published that uses imaging to get to this diagnosis. Now, I did find 3 papers on Parkinson's, and 2 of them seem to show that the vagus nerve is smaller in Parkinson's disease patients. So there, the vagus nerve is probably dying off, if you will. But then the 3rd study kind of came and, threw some hot water on that idea, because that study didn't show a difference in size in Parkinson's patients between the vagus nerve and normal controls. So ideally, this is the thing we would want to see, right? We'd like to take out our ultrasound probe in a patient that's having these vagus nerve symptoms and CCI. We'd like to put it on the neck. We'd like to measure what's called the cross-sectional area, or how big the nerve is. And we'd like something like this. This doesn't exist right now, but this would be perfect, right? If it's between these 2 measurements, then we know it's normal and it's not a problem. And let's say if it was much bigger and between these 2 measurements, it was abnormal, and we know that the vagus nerve is commonly associated when it's that big with all these vagus symptoms. So we'd like to take a bunch of CCI patients who have no vagus symptoms and a bunch of CCI patients who do have vagus symptoms and see if their nerves are any different. And in fact, given that there's no research on this, and I don't like producing reports out of thin air without any real information to say that what it is I'm measuring is normal or abnormal, we're going to do this study. We're not going to charge for it. We're not going to go ahead and produce some sort of crazy report that's relatively meaningless. We're going to go ahead and take a look at what the size of the vagus nerve looks like in patients who have vagus symptoms versus patients who don't have vagus symptoms. And we'll do it in a blinded fashion, so no one really knows what they're doing, meaning which patients are which. But the goal is to see if we can come up with some way to say, okay, this group of people over here have some very serious vagus nerve issues, and that's associated with these vagus nerve symptoms. And this group of CCI patients over here, for whatever reason, have no vagus nerve issues. So again, this is part of our ongoing commitment to dig deep into this stuff, to finally start doing and publishing some of the research that defines this space. Why? Because one of the reasons why patients go out there and they start seeing doctors who have no idea what's going on is because of the lack of that published research in CCI. We've got a little bit of published research, not much, frankly, on surgery. But outside of that, your average doctor's got really nothing he or she or they can sink their teeth into. So by trying to get some of this research published, that'll help patients in the future. Hopefully one day a patient will show up with CCI and a family doctor would say, I think you might have CCI. Let me send you to someone who can ferret that out. Doesn't happen now, but we could get there if we keep digging deep into what's going on. So in summary, vagus nerve problems can be caused by CCI. We don't yet have a way to diagnose these using ultrasound imaging, but we'll be starting that study. So let me stop the sharing here and I'll go to see if we have any questions for today. Looks like we do. Okay. Bethany, I understand to know my blurry vision dizziness from CCI seems to be worse when looking up or down versus left to right. What could be the reasons for this? Certainly if you're looking into flexion, that could be irritating. And I think I talked about this in the last, maybe the last video or the video before that there's a superior cervical sympathetic ganglion up here. And in that position of flexion, you may be irritating that ganglion, which then affects the pupil size and the amount of light that's coming into the pupil, and that can cause blurry vision. Lissy, is headache the only symptom for C0 only? Not necessarily. All of the upper cervical joints provide position sense information to the brain about head or neck position. So you can also get dizziness and balance from any one of those joints, C0, C1, C1, C2, C2, C3, in addition to headache. Andy, you mentioned in your earlier videos that you only treat the POM when you're absolutely convinced it's a problem area. What do you look for when deciding whether or not to treat this ligament? Yeah, Andy, it's not hard to see on MRI. Let's see here if I can find just a routine cervical MRI picture online and show you where it is. Let's see if I can find a good picture here. Yeah, this is a good one. Okay, let me put that just quickly, Andy, in a PowerPoint presentation so I can draw on it. Okay, so let's get rid of that one. Okay. Okay, this should work. So this is the PAOM back in here. So posterior lennooccipital membrane, you see part of the rectus capitis posterior minor muscle here. This is the back of the skull. This is C1. Should be able to get it's not giving me something to draw with. Oh, well, we'll have to do the best we can this way. But bottom line is this is the PAOM. Now, since it's a black line like this, and it's easily seen, you can generally see if it's damaged. The other thing you can see with PAOM, which has to do with this muscle here, rectus capitis posterior minor, is rectus capitis posterior minor will send a little twig of a tendon into here. And the goal of that tendon is to pull that rectus capitis or sort of pull that PAOM out of the way when you come into extension. Because if you come into extension, it wants to buckle. And you don't want it buckling because that could irritate the brainstem, spinal cord, etc. Now, in flexion extension MRIs, such as the type that Dr. Rosa does, you can sometimes see it buckling, and that's due to problems in the PAOM and also problems in the rectus capitis posterior minor. So when we see it buckling, or when we see some sort of damage to it, we can treat the PAOM and we can treat the rectus capitis posterior minor. So I hope that makes a little more sense now. Andy, when you're treating a POM, do you typically treat the middle portion of the ligament or treat it laterally, as usually enough to treat it down the middle? Given that it's safer to treat it in the midline, we'll usually just treat it in the midline. The problem is it's a circular structure or a semicircular structure, and it's not that easy to see under ultrasound imaging. It's actually better to do it under contrast with fluoroscopy. So since we're doing it that way, it's usually the middle. Now it'll spread pretty well. We've never had a problem with it. But if you go too far, the problem is that you're in the dura and you can cause a dural leak. Now the dura is pain sensitive, number one. So you don't want to be in the dura or inject into the dura. And number two is you don't want to poke a hole in the dura, because if you do, then you get a spinal leak. Diana, hydroxyl Centeno will cause the bobblehead sensation. I'm surprised that some don't have it. Is there a bilateral alar injury versus unilateral? I think for most patients, Diana, they're getting that because of the multifidus atrophy or the cervical segmental atrophy that we've talked about that happens in those upper neck muscles. So for instance, of the 4 telemedicines I did this morning, 3 out of the 4 had a lot of atrophy in the upper neck muscles. So it's pretty common. One was 80% atrophy. So that's going to cause that bobblehead type sensation, because the active muscles that are supposed to stabilize the bowling ball on the stick just aren't doing their job. John, is the imaging done by NUCA and AOC chiropractor sufficient, so CCI, or is DMX necessary? Generally, the imaging done by NUCA and AO chiropractors is specifically only to get vectors for adjustment. So what that means is what they're looking at is the position of the skull versus the position of C1 versus the position of C2. And they're doing that so they can see, is it 11 degrees rotated at C1, C2 off to the right, for example, in which case I use a certain vector and a certain force to put it back. They're really not looking for instability. So if we're looking for instability, again, CCI, craniocervical instability, we have to have a motion-based image like DMX. Now, for instance, one of the telemedicines I did this morning, the patient had an upper cervical chiropractor who had done an open mouth lateral bending view, and there was some C1, C2 overhang on that. So that was valuable for me to have. We're still going to get a DMX because he didn't really push the patient that hard, and it was right on the limit of normal abnormal, but it was certainly the kind of thing we would look for. Regenics, mid-advanced by Patricia R. Ford. Will you discuss how CCI symptoms are position related? I get more symptoms from sitting too long, from laying left versus right, and from different degrees in which I tilt my head. Yeah, so that depends on where the ligament injuries are. And that's a good topic because it brings up also treatment, right? So for example, as we've been talking about, if you look down and you've got CCI problems, there's a number of possibilities there for ligaments that could be injured. So if you get symptoms when you look down, it could be the transverse ligament. It could be these posterior ligaments back here. Now, that's a reasonable thing if you've got translation of one vertebra on the other in flexion, then you can do posterior treatment and usually have that work. It's not going to work if it's the transverse ligament because that's internal, but it will work if it's one of these ligaments back here. So about half of those patients you can help with just posterior injections, and about half of them won't respond to posterior injections because it's an internal ligament that you can't get to from the back. Another example, as you talk about turning your head a certain direction or laying on the right or left, That's usually an alar ligament on one side and not the other. So that's a really common thing where I can lay on my right side, but if I try to lay on my left, all bets are off. Now, why is that? Those alar ligaments come up like this from the dens and go to the skull. So they're going to stabilize laterally. So those are just some examples. John, why does strengthening my shoulder scapula muscles make my neck feel more stable? I'm a hypermobility patient with minimal overhang, normal flexion extension, and probably posterior instability only. Realize that it's all connected, right? We say things like shoulder, we say things like scapula, but really in the body, there's no such thing, meaning that we have a cervical brachial complex that goes from the neck into the shoulder and upper back. And that cervical brachial complex has muscles that are shared by both sides. You've got scalenes that start way up top and in the middle of the cervical spine, for example, and go into your first and second ribs. You've got a levator scapula muscle that goes from your scapula and goes up to the neck. So there are connections between all of these things. So stabilizing that in your shoulder is stabilizing part of the core. Now there's an internal part of the core that lives deep inside here. And that kind of internal part of the core is a little different because that's the multifidus we were talking about before. But listen, if that feels better, then continue to do it because that's a great thing. You're stabilizing parts of that cervical brachial complex or muscles that are shared by both the shoulder and the neck. That's been advanced by Fat Chen. How long does it take for bone spurs in the spine to form? How can bone spurs cause spinal leaks? Let's go backwards first. Bone spurs generally don't cause spinal leaks at all. And a bone spur is not some sort of insidious, awful thing. It's just your body's response to instability. Your body is trying to stabilize the joint, so it adds more bone. Now, there are times that bone spurs can cause problems by themselves, but 90% of the time, they're innocent bystanders, and they are just what happens when someone's unstable. And it doesn't take long for them to form. If you look at animal models, now things happen more quickly in animals. They have shorter lifespans. But in animal models, 4 to 12 weeks, and you've got a bone spur. So they're not something that really take years to form. Travis, hello, Dr. Centeno. I recently had 6-7 fusion in August. I've had all the symptoms of CCI for years, but since my fusion, they're a lot worse. Yeah. Travis, well, regrettably, that is a super duper common complaint that we see. So lower cervical fusion is contraindicated in a CCI patient. And what contraindicated means, it's a fancy medical term. All it really means is we shouldn't do it as a doctor. And the reason we shouldn't do it is because if I fuse a level down here, that means that those forces have to go someplace. And they're going to go up into the neck and down in the thoracic spine. Now, if you're already unstable up top, and we start fusing stuff down here, it just puts more forces up top. So it's a super common problem that we see patients who get lower cervical fusions, where it makes their CCI much, much worse because it is worse. You're putting more forces. So lower cervical or mid-cervical fusion would be contraindicated, meaning shouldn't do it in a patient who has CCI for that reason, because you're going to overload that upper cervical spine, which doesn't have good stability to begin with. Regenix been advanced by Fat Chen. Why do some people with CCI have myoclonus jerks? Which structure is affected that cause this? Only people with EDS get myoclonus, and which medication helps? Yeah, myoclonic jerking is certainly a CCI symptom. We don't see it as often. It's probably in 5 or 10% of the patients. And generally what that means is something like that, almost a little bit like a tremor, but bigger. So the first thing is trying to differentiate it from fasciculations. Fasciculations are where the muscle jumps on its own. And fasciculations are super common in any pinched nerve situation in the neck or the back. But if it's true myoclonic jerking, we have to make sure we obviously rule out a bunch of neurologic diseases that can cause that. But if it's being caused by CCI, I suspect that it's just part of what's called neurologic fatigue. So I'm not sure if you've ever done any rock climbing, but rock climbers, especially new ones, are famous for getting their foot to shake. It doesn't really shake. It's kind of like a constant reflex that happens in their Achilles tendon. And it's an example of neurologic fatigue. Our brain is constantly inhibiting those spinal reflexes, like the one that would cause your foot to go like that. And when it can no longer inhibit that, those things come out. So it's probably that same kind of neurologic fatigue. Isabella, I suspect that cervical instability, and I have cervical instability with following your x-ray instructions. Would a CT scan be a nice addition, or x-rays enough? What kind of CT would you recommend? Listen, as I always say, I really will never turn down more information. More information is always better than less. Having said that, we should obviously be as efficient as we can with our imaging information gathering. A CT has an immense amount of radiation, about 100 chest x-rays. So the amount of radiation you're exposed to in a CT is off the charts. So because of that, we don't normally recommend CTs. You'd probably do much better to get a functional MRI and the open mouth lateral bending x-ray views, because you'll have very little x-ray exposure to the open mouth lateral bending views. And then you won't have any x-ray exposure if you're getting a functional MRI. So those are the two things I'd probably recommend. If only a CT is available, let us look first at the open mouth lateral bending views. And then if for some reason we can't get there just using those views, we can always get a CT. And that's going to be a CT with head rotation, following the 1987 paper by Jiří Dvorak, where he looked at normal versus abnormal for that. Jim, why is it rheumatoid patients with C1, C2 instability typically have a primary complaint of pain, headaches, where CCI patients have all sorts of neurologic symptoms? Well, let's back up a little bit. So when it comes to classic CCI is headaches, pain right here, and imbalance or dizziness, etc. And then we can have all sorts of symptoms that are added on, autonomic symptoms like the kind we're talking about with the vagus nerve today. Now there's atypical CCI where someone only has autonomic symptoms. That's all they have. We see those too, and that's a more interesting sort of concept. But when it comes to rheumatoid arthritis patients, realize it's a little bit different. Number one is that's happening over many, many years. It's usually not just a sudden traumatic thing. In addition, you're probably also destroying some of those same proprioceptors through the rheumatoid arthritis that so confuse the system in CCI patients. And then again, you do have autonomic symptoms that happen in rheumatoid arthritis patients, but they're probably a little bit more like the Parkinson's patients. They tend to be older by the time they're getting upper cervical dislocation. So for instance, you're seeing a vagus nerve that's smaller and dying rather than a vagus nerve that's pissed off. So let me give you a good example of a nerve in your hand so you can understand that. When a nerve in the neck or here in the carpal tunnel gets irritated, it becomes hypersensitive first. Once it's dead, this is just numb. It doesn't hurt, it's just numb. Where it hurts and becomes hypersensitive is the early part of it getting pissed off. But once it's dead, it's dead. So I suspect in many of these rheumatoid arthritis patients, we're seeing neurologic systems that are dead, not neurologic systems that are pissed off like we see in our CCI patients. So the good news is most of our CCI patients have an earlier form of neurologic irritation. Now you can take that even further. We talked about the eye issues and that superior cervical sympathetic ganglion. If I kill the superior cervical sympathetic ganglion, then that eye pupil constricts and stays constricted. But if you just piss it off, the pupil gets bigger. So the body has a dramatically different response to nerves that are pissed off versus nerves that are dead. Rosalind, you said earlier that C1-C2 instability can cause vagus nerve rotation, so can C2-3, can 5-6. Less likely, because what happens in most people is the course of the nerve moves farther anterior and away from the front of the neck. Now, could it be possible? Could it be that someone has an aberrant course of where that nerve goes? Sure, we're all put together slightly differently. And that's something you can check on an ultrasound in 20 seconds. You can see exactly where that nerve is living because it's pretty easy to find. Lissy, can young patients at age 19 start getting arthritis or osteoarthritis in the spine or at an older age? If you're getting osteoarthritis in the spine at age 19, there's probably something that has happened, right? Either a really big trauma with bunches of instability or some other genetically related disease. So the answer is not generally. Isabella, in addition to neck problems, also shoulder pain that seems to relate and worsen the neck problems. What's the best way to treat shoulder problems and which ligaments specifically? We first need to find out why you have shoulder pain. So we just create a diagnosis list 20 items long, just with that one concept. So let's just go over a couple. For example, you could have shoulder pain due to osteoarthritis of the main shoulder joint, osteoarthritis of the AC joint, osteoarthritis of the SC joint. Then we get into rotator cuff tears. You can have shoulder pain related to supraspinatus partial tear, supraspinatus complete non-retracted, supraspinatus fully retracted, subscapularis, infraspinatus, teres. We're just not even through a small portion of the list, a C5 nerve in the neck. So we got to get to what's causing the shoulder pain before we can decide how best to treat it. It's been advanced by Harry. You may have mentioned already, but when will you be away this spring for the purpose of scheduling? Yeah, I'll be gone from 4/23, April 23rd through June 3rd. So if you want to get in prior to me going away, then this is definitely the time to schedule it now, because too much later and there won't be time on the schedule. And then I'll be back June 3rd. So that's the time I'm going away there. So obviously that'll put a little pressure on the schedule on either side. Jim, I read your study that showed 12.5% dextrose treatment reduces flexion instability. Study performed 3 treatments on patients. How many PRP treatments would that equate to? Generally, in my experience, it's half. So 1.5. Can you make a video on Monday why traditional chiropractors make instability worse in different parts of the spine? I don't know that most of them do. What I do tend to see, Ulysses, is that we have a whole case series of patients, probably numbering at this point 24, who relate their CCI to a long lever cervical chiropractic manipulation. So that's when they take the head and go like that. Now, does that happen often? No, it's probably happening 1 in 1,000 or less, probably even less than that, maybe 1 in 10,000. But I think it can happen. Now, that's obviously very, very different than AO chiropractic and NUCA, which is very precise and very, very small types of motions. But those long lever type head rotations do seem to occasionally cause CCI. It's been advanced by Beth McCoy Anderson. Why is it that a patient with CCI gets lightheaded when they lay supine on a pillow or also in side lying? But if they prop their head up even ½ an inch in the same position, lightheaded symptom goes away immediately. Is this pressure on the vertebral artery? Same person feels better on stomach with head to the left, vestibular battery negative, overhang 5 and 7. AO has helped issue. Yeah, Beth. So this is why it's critical to understand that there is, we all talk about CCI, right? This big circle of a Venn diagram. But within that Venn diagram, there's lots of little circles because there are lots of sub-diagnoses. So for instance, CCI with right alar ligament laxity, CCI with left alar ligament laxity, CCI with bilateral alar ligament laxity, or AAI. AAI, alenoaxial instability, which is a part of CCI with transverse ligament laxity. Add in PAOM, tectorial membrane, the SAAOL. I mean, we quickly get into dozens of different types of CCI. CCI due to adjacent segment disease because they've fused the lower cervical spine right below the area. CCI due to scoliosis because, as I've already lectured on, you get chronic C1, C2 rotation due to the side bend. So I think what you're describing is a patient who is getting lightheaded when they're on their back, and then when they're on a pillow, or let's just go with the pillow, right? So when they're in a pillow, they're flexing their neck. So there's something about being in that extended period position which is causing instability. To me, the first thing I think about would be an anterior injury, and that would mean to the AAOM, the aleno-occipital membrane up front, or to the SAAOL, or the AAOL up front. Those are the ligaments that live between the skull, the atlas, and C2, and are various types of extension of the anterior longitudinal ligament as it goes north to the skull. So that would be one thing that would explain that. But now we've then got to get a DMX and see what's happening there. Or maybe since there's already overhang on the DMX, I'm assuming it could be part of how their alar ligaments are positioned, because realize that's not even constant. So we've got some alar ligaments that come straight out. We've got some alar ligaments that come forward and some alar ligaments that go backwards. So again, depending on how those alar ligaments are positioned would also fit into all of this. Rosalind, you said earlier that C1, C2 instability can cause vagus nerve rotation, and so can C2-3. I think I got that one already. Pino, what is your opinion on stem stella derived from umbilical cord? There's no such thing, not here in the United States. So that's a scam. So there's, we've actually done the best study on this to date. It was published in the world's most prestigious orthopedic journal, the American Journal of Sports Medicine. We tested 6 umbilical cord products who all claimed to have live stem cells. And that was a co-joint study between our lab and Colorado State University and their Translational Medicine Institute. There were none of those products that had any living stem cells at all. So that's a scam. If someone is claiming to you that they're injecting umbilical cord stem cells, they are scamming you, and I would run the other way very, very fast and hard. PIA, does the PAOM have a function to keep the head up so it does not fall back? Really the opposite direction. So realize that the PAOM is going to prevent the skull from rotating forward, and those same ligaments I was just talking about in the front are going to prevent it from going backwards. And what I was talking about with head extension is that the PAOM can buckle if the rectus capitis posterior minor muscle is not functioning. So that's how that all works. But good thinking, because this is the kind of stuff I think we all need to be thinking about, right? We all need to be talking about the types of sub-instabilities and what kind of treatments do you need based on what kind of instability you have. And that's all got to be customized to the patient. And so, for instance, some patients will get better with posterior injections only because of the type of instability they have. Some patients won't get better that way because of the type of instability they have. So, very good questions asking about which ligaments do what. Sharon, hi, Dr. Centeno. I missed the first 15 minutes of this topic about the vagus nerve. We discussed things like gastroparesis. We did touch on it a little bit, but really where we were going with this one is how do you diagnose a vagus nerve issue in the neck? Sharon, I did say that what we're going to start to do with all of our initial vals and follow-ups in the office is start to measure the size of the vagus nerve on ultrasound, and then look to see if that size relates to people who have vagus autonomic symptoms like gastroparesis, like POTS, etc. Because it would be, again, as I talked about, getting research out there about this condition is what would create a world 10 years from now where the average family doctor would say, oh, you might have CCI. It doesn't happen now. And I know it drives you guys insane, and it should, that you go to these doctors and they look at you like you're crazy, not because you're crazy, but because they don't know what they're talking about, or they haven't really read about this or been taught about it. Well, the only way people get taught about things is we put stuff in the peer-reviewed literature. So that's the goal, is to get that information in there. Can we use an ultrasound machine to see if their gastroparesis is being caused by their neck? Now that would open some eyes on the GI side, right? You would have a whole bunch of GI docs go, wow, I didn't know you could do that. I didn't know these things were related. Now I know. That's what we're trying to get to. Kimberly Kreft. My heart rate, nausea, and blood pressure issues, vagus nerve symptoms have improved so much with posterior upper cervical injections. Good. I still have a scaling tightness and pain that spreads elsewhere, and increased functional activities, daily activity. Could this be vagus nerve or thoracic outlet? I'm assuming I still have CCI instability. Yeah, so the scaling muscles are like, if you've ever seen a sailboat mast, you may notice that there's a bunch of wires that come down that hold up the mast. And that's what the scaling muscles are to the neck bones. They're the guy wires that hold it all up. So if you still have side-to-side instability, then those scalings are going to be in overload mode. And then that's going to cause all sorts of problems like thoracic outlet. Now, could be other things causing this as well. I'm just postulating here based on what it is you're telling me. But that's something I would be looking at. You may have atlantoaxial C1, C2 side-to-side instability that generally can't be fixed from posterior injections. And so while the posterior injections may have helped, let's say C2 going forward on C3, which was pissing off the vagus nerve inflection, they did nothing for the side-to-side instability. And then so your scalings are kicking in, holding on for dear life, trying to stabilize that, and they weren't built to do that. So one thing to think about. Sharon, in case you haven't discussed gastroparesis, this could be from vagus nerve, or just an EDS thing. What if there are no other CCI-like symptoms? Would it be likely to be EDS? Yeah, it can be common in EDS patients. And so the question would be why? My guess would be that a certain percentage of those EDS patients would have it from the stair-step instability that they tend to get when they flex forward. What I mean by that is 2 goes forward on 3, 3 goes forward on 4, 4 goes forward on 5, and that's banging into that vagus nerve, leading to gastroparesis. And then obviously you probably have another subpopulation of CCI patients who have a completely different mechanism. That's over my pay grade because I'm a neck guy. Andy, can evidence of mild atrophy confirmed in MRI along the extensor muscles near C2 bone be causing heavy head? In your opinion, would these muscles or the POM be likely the primary culprit? Well, if you have atrophy of the deep segmental muscles there, that the multifidus, those are the muscles that help to stabilize the bowling ball on the stick, the head on the spine. So that's probably more likely to cause heavy head. I'd have to look at your MRI to really get a sense of it. But I could probably look at your MRI in all of 20 seconds and tell you and give you an answer, because it's not hard to figure out. As far as the PAOM, that's another easy one to look at. So if you schedule a telemedicine visit, I'm happy to look at those things to try to see which of them looks more likely just based on the imaging you have. Isabella, is there cervical instability with overhang, and is this related to posterior PRP? Cervical instability, will that added stability from sets encourage alar transverse ligaments to heal on their own? Generally not, Isabella, no. As I've said before, when we first started doing PICL procedures from the front, we would force everybody to do posterior injections first. Our thinking was we really didn't know what the risk of this was. So we did know what the risk of those were. So we wanted to put everyone into that group first. And what we saw is those folks that had C1, C2 overhang were only about 1 in 5 times likely in order to, only 1 in 5 of those patients got better. And that makes sense, right? That motion, C1, C2 lateral overhang, is primarily controlled by the alar ligaments and the accessory ligaments. We weren't coming anywhere near the alar ligaments and accessory ligaments by injecting posteriorly. So I wouldn't waste resources, time, energy, and money if you've got a good amount of overhang trying posterior injections. It's worth trying it once or twice because you could be in that 1 out of 5 patients, but you're 80% likely to be in the group where it doesn't work at all. And that makes sense because we're not injecting those. So no, there's nothing about injecting posteriorly that's going to make the alar and transverse ligaments heal on their own. That wouldn't work too well. Sharon, can overhang be fixed by just posterior injections? Just answered that one for Isabella. So I think, so the answer is no, but I gave a more detailed explanation. Sharon, does the curve come back naturally as a result of instability? My AO doctor tells me not to do CBB because you're forcing the neck into the right curve. It's confusing. It generally doesn't come back on its own. So some supportive things. The first would be many of our CCI patients can't really do curve restoration because they've got too much instability up here. So in those patients, you've got to stabilize this first. And in addition, you can do posterior injections to try to promote that, but you still need to get the curve back. So generally it doesn't come back naturally. I think maybe what your AO doctor is talking about is he may not think you're stable enough to tolerate it because it can throw things out up top if you're not stable up top. Ulysses, have you usually seen whiplash patients that are not related to CCI? Oh, sure. Yeah. I mean, Ulysses, most patients who have whiplash don't have CCI. So that's just a tiny fraction, 1%, 2% of patients with chronic whiplash type pain have CCI. About 20% of them have upper cervical injuries, but only a small percentage of those have CCI. Pia, how common is minor instability in the cervical neck, around 1 millimeter? Not quite sure which direction you're talking about, and it does make a difference. So for example, if we're talking about C2-3 in flexion translation, 1 millimeter is the cutoff. Anything more than that is abnormal. If we're talking about 5-6, 1 millimeter translation is totally normal. If we're talking about C1, C2 overhang side to side, then 1 millimeter is normal. So a lot depends on where it is we're talking about. Eric, if you fuse C0 through C2 and developing adjacent segment disease and progressing subaxial instability, can PIC on the lower cervical spine be an alternative to prevent further fusion surgery? Not quite sure what the question's asking. So it predicates on the idea that we fuse the upper cervical spine, 0 through 2. And so once we do that, there'd be no need for PICL because you're fused from the skull down to C2. Now, adjacent segment disease would then be likely at C2-3 and C3-4. So we do treat adjacent segment disease after fusion, including upper cervical fusion at the lower levels. So I think maybe that's what we're talking about here. But just realize that once you get fused at 0 through 2, all bets are off. We're constantly playing or chasing that breakdown at 2, 3, and 3, 4 that's going to occur due to that adjacent segment disease. But listen, if you got to get fused and we're trying to help 2, 3 hang in there, that's a good way to go. Sharon, what are your thoughts about improving overall posture prior to injections? Yeah, very important. I talk about it a lot with patients, opening up all of this, getting that head and neck back, getting rid of this kind of thing. Because realize that when you're doing this kind of thing or your head's coming forward, you're putting immense amount of pressure on those upper cervical ligaments. So you want to get rid of that and offload that. How do you test for RA if blood tests are negative? Generally, it's blood tests. Now, listen, I'm not a rheumatologist. I don't do rheumatology. But RA right now, medically, is only diagnosed through blood tests. Or, obviously, if you have some sort of destructive lesion in your upper cervical spine or destructive lesions in your hands that look like RA, I guess that's another way you could do it too. Jim, do you think 70 years from now there are going to be advancements in regenerative medicine where ligament surgery and fused surgery is going to be abolished? Oh, sure. It'll happen much sooner than that. I think we'll probably see a 2/3 reduction in fusion surgeries over the next 10 years. And we're already seeing that through the Regenix network, meaning we have 1,200 employers now who have signed up, 1,200, who have full coverage for everything we're talking about. And the fusion rates in those patients has dropped like a lead weight in water. Meaning that, if the number of fusions for an employer were this, they're now this. So we're already doing that on a daily basis. The only thing that really requires is, number one, training lots of doctors how to do it. And we've got 100 different US sites. We'll probably have 300 sites in the next 2 years. But that's not enough to take care of, for instance, United Healthcare. They would need many more than that. So it's, number one, training enough doctors. And then number two, simply getting enough widespread coverage through insurers where it's directly competing head to head on the same level playing field with fusion, like it is for our 1,200 employers, meaning that if you're covered by one of those employers who has the Regenix program, all of this is covered. Everything we're talking about is covered. So if the patient could do this and not have to pay any more, obviously that's a game changer. John, is it possible to not flex far enough in an upright MRI? How do I tell if I did enough flexion? John, you definitely want to get as much flexion as you possibly can. How far? Obviously, that's going to be different from everyone. Normal flexion is being able to put your chin to your chest. Now, one of the things, if you can't even get close to that, you might consider is having a local doctor give you a prescription for Valium, 10 milligrams, or a similar type of drug, which will relax your muscles and make you a little sleepy. Now, you'd have to have a driver. Or if you get a lot of pain with that, taking some pain pills before you go and having a driver. But you want to get as much as you possibly can. Jim, do you have to fast for 8 to 12 hours before a PRP blood draw? Not 8 to 12 hours. We usually just recommend an overnight fast, which means skip breakfast, because we do all of our draws in the morning. So that should work just fine. Now, is it going to destroy things if you don't do the fast? No, because there'll be a certain percentage of patients that don't have that same metabolic syndrome problem that many Americans have. So this is just to adjust for, American style metabolic syndrome. Andy, can evidence of mild atrophy? I think I got that one already. Richard, if your jugular vein is being compressed between C1 process and the longoid styloid, cause tinnitus, and what should it sound like? So Richard, be a little careful with the concept, primarily because If we were to go take 100 people off the street right now who have never had a day of any problems related to their neck or tinnitus or anything else, and we were to do studies of that internal jugular vein, which is what we're discussing here, about 1 in 3 will have moderate to severe compression of that internal jugular vein and no problems at all. So the big question would be, which patients who have that problem have it causing symptoms, and why is it happening? So frequently it's happening due to CCI. So we treat the CCI to see if it goes away. Many times it does. If it's still there after the CCI is treated, then you can always get the stylohyoid ligament cut, which is what you're talking about. There's really no such thing as an elongated styloid process as much as there is a calcified stylohyoid ligament. The problem is once you do that, you're going to destabilize the anterior neck. So we generally don't want to do that if someone has instability causing that problem. Bethany, I just saw an ophthalmologist for blurry vision and pressure. She said that the pressure in my eye is normal and I only have slight astigmatism. Could this exam be normal even though I have eye problems from CCI? Absolutely. Yeah, most of our CCI patients don't get answers about why their eyes are having issues because it's things like the pupil not functionally working like it should, or the eyes tracking together, which would require a smooth pursuit neck torsion test to detect. So yeah, in fact, we always want our CCI patients to get that normal bill of health from ophthalmology because we don't want there to be some other problem that we missed. But yes, that's 99% of the time what happens when they see an ophthalmologist, because the ophthalmologist isn't measuring the kind of things that cause these visual problems. Isabella, I have an appointment with Dr. Kirkor. Do you know if he can diagnose my shoulder problems? If not, is it bad for you to do PRP in the neck without treating the shoulder simultaneously? He should be able to diagnose shoulder problems. Sure, yeah. Isabella, my right shoulder has a throwing injury from softball, and there's just a general weakness, cracking in the whole area. Therapy, the shoulder heads have worsened my shoulder problems. We would need to diagnose what's causing that weakness, cracking in the whole area. So again, as we talked about, lots and lots of different possible diagnoses there, labral tears, instability of various joints, rotator cuff tears, et cetera, problems in the neck, causing issues in the shoulder, long list. So we have to get to a diagnosis before we apply a treatment like prolotherapy. Lori, what's a functional MRI? Just means in this context, an upright MRI with motion. It's been advanced by DB. What's the treatment for vagus nerve issues? I don't think I have CCIs. My symptoms are mostly anxiety, inflammation, physiology symptoms, mimicking gallbladder. So here, DB, we're focused on neck-caused vagus nerve issues. So not an expert in how to treat vagus nerve issues outside of CCI and treating the neck. Yeah, Lori, when I'm out, I will still be doing probably a couple of these now that we have a good internet connection over there. I'll probably be doing a few of these here and there. So you'll still be seeing me from time to time, but I will be taking a little bit more time off during that time period. Megan, I recently improved enough to go on walks again after alignment with AO. Vertigo and astigmatism for revision have become rare. However, I noticed that the horizon seems to be bouncing with each step. Does it indicate continued disconnect with the eyes and the brain? Yeah, or more like the upper neck still giving bad information to the eyes. That generally sounds like nystagmus, or the eyes not being coordinated, and that can be an upper neck issue. So there still may be some upper neck treatment to go, and if that doesn't help, then someone should look at the upper neck facet joint, C0, C1, C1, C2, C2, 3, to see if they're causing that eye jumping, because bad information from the neck, remember, is what improves that eye tracking and improves many of those symptoms. And then, listen, guys, I'm going to be wrapping it up pretty soon. So I'm just going to go through the list here and try to find questions that are unique. Diana, should we address TMJ before PICL? Yeah, never seen PICL bring out jaw issues, so I haven't heard of that one. But certainly if you have TMJ issues, if you can tolerate it, we generally treat them at the same time because TMJ issues are common in CCI patients. Let's see. Sorry about that, guys. Lori, I saw an AO chiropractor to confirm upper cervical instability. I have so many neurologic symptoms, blurry eyes, dizzy, off balance, etc. The newest is a sense of rocking like I'm at sea. Cause. Yeah, so the dizziness is generally caused by bad proprioceptive information coming from the neck, and that's used to help control vision, and that's coordinated with information from the inner ear. So the sense of rocking is usually in the case of someone with upper neck problems due to bad information coming in from the upper neck. Pia, about my question with segmental translational values. Yeah, Pia, so it's generally considered anything more than 1 millimeter at C2-3, and then once you get to C3-4 all the way down to 6-7, it's pretty much the same. Anything more than 2 to 3 millimeters of translation is abnormal. More abnormal when you get towards 3 and above. Pino, do you personally accept new patients for the Cayman procedure? Absolutely. I think I answered that one. Yeah, we just had a patient like this who had a tongue tie release, made CCI much, much worse. Again, it's a little bit like cutting the styloid. You're doing something that's destabilizing the anterior neck. And while it may help one set of things, it's going to make another worse. I think I got everything. Isabel, is possible to send the x-rays to help with diagnosis? Yeah, that would be part of just a telemedicine evaluation. And then finally, Rosalind, my right pupil has been permanently smaller than the left since I damaged my neck. When I go to lay down, it becomes pinhead size, stand up, and it grows. Yeah, so that's likely the superior cervical sympathetic ganglion. If you just go back a couple videos on my YouTube channel, there's a whole video on the superior cervical sympathetic ganglion and how it controls eye pupil size. So that sounds exactly like that. Isabella, are there any negative effects to posterior PRP, or can things get worse? Things can always get worse in sensitive, fragile leg patients, regardless of what you do, whether it's posterior injections, anterior injections, surgery, etc. And then last one, can weather affect CCI symptoms? In my experience, any type of joint pain can be made worse by weather. The joints act as little baroreceptors or pressure receptors. So if the pressure gets less out here, those swell, and if they're already painful, that can definitely make things worse. Okay, guys, so I think I will be here on Monday, and I think on Monday I'm going to talk about how to dissect all of this stuff that we've been discussing regarding which ligament is damaged and which treatment do you need, because I think there's still a lot of confusion there. About, what kind of things does posterior injections work for? What are the different kinds of posterior injections? Because, I've heard that term thrown around, and it's massively different based on the skill levels of different clinics. So you've probably got 3 big types of posterior injections out there, one having very little to do with the other. And then, so I think that's what I'll talk about, because I think that's where there's still a lot of confusion. What ligaments likely cause which issues? How would those ligaments be treated? And then what are the differences in all these treatments? Because, as an expert in this area, when I hear posterior ligaments, is it the first type, the second type, the third type, the fourth type? Are they going to inject the facet joints for real? Are they going to fake that? So that's all stuff I think we'll talk about on Monday. So you have a wonderful weekend. Thank you so much for all your great questions. There's no bad questions here. Every question is great because it always helps us to learn and it helps us to understand what's going on. And there's nothing worse than having vagus nerve issues like we talked about today, because they can really make a mess of the whole system, everything from the GI tract to the heart to even how you handle inflammation. So have a great weekend, and I will see you on Monday.